I am a simple clinician. I see patients with neurological illness, particularly with neurodegenerative diseases. And so my talk is going to be much more focused on some of the nuts and bolts issues of dementia with Lewy bodies. I guess it goes by different names. Carol kept saying Lewy body dementia. I'm going to say dementia with Lewy bodies, or DLB, but she's probably more up to date on what the accepted terminology is. The main thrust of my talk is going to center around these messages. First of all, dementia is not normal aging. There is, I think, still a very profound misconception in the community among physicians and laymen alike that people developing cognitive problems as they get older, that this is part of normal aging. It's not. While it's common, it is certainly not normal. Furthermore, dementia with Lewy bodies is not rare. Indeed, I think that the estimate that Carol mentioned, about 100,000 people in Florida, I would not be surprised at all if it's double that. These are very common disorders, but they very often go unrecognized by physicians who are not used to looking for them. Again, a very practical point that I cannot overemphasize, and I think Carol was good enough to make a copy of a card about medicines with patients with Parkinsonism should never, ever, ever take. These are neuroleptics. These medicines are absolutely to not be taken by patients with Parkinsonism, including dementia with Lewy bodies. I want to, and at the very end, I want to leave you all with the concept that neurodegenerative dementias and other disorders currently, as obviously everyone in the room knows, are not curable, but they are treatable. Many aspects of these disorders that produce problems for daily living can be alleviated. And again, I want to emphasize that there is a lot to be hopeful for and about regarding these diseases. And again, I'll be more explicit later in my talk about that. Dementia is a word that is, I think, used in a variety of ways. And if you look in various texts, I'd be interested actually in that textbook that Carol was holding up, exactly how the author of that defines dementia. But this definition, I think, is a reasonable one that most, if not the vast majority of clinicians who see patients with dementia would agree with. Dementia is a progressive, so it is an ongoing reduction in the intellectual and social functioning, pre-morbid meaning before the onset of the disease. And this involves multiple cognitive spheres, with short-term memory or recent memory being a common one, but not the only one. Others include language problems, so a person having difficulty both expressing themselves using language and also comprehending spoken language and written language. It also includes difficulties in basic mathematical skills, so basic arithmetic. It can include problems with judgment and insight. It can include problems with visuospatial skills. These are essentially our ability to be able to see our environment in 3 dimensions. And also, this can involve behavior. These, again, a person may have difficulties in multiple spheres that I've just enumerated, and these are such that it interferes with the patient's activities of daily living. So again, I'll be interested if Dr. Stewart agrees, but I think this is a reasonable global definition of dementia and what we're talking about. Okay. Some basic numbers, and again, I think these are definitely conservative estimates, but the prevalence of dementia in North America is doubling every 5 years. And if you think about the fact people are living longer, it's not really a mystery why that is. At the age of 65, about 1% of people would meet criteria for a form of dementia. But again, if you think about people who are in their 10th decade, so patients in their 90s, over half of them will meet criteria for dementia. So again, with most people, the majority of people living longer, we're talking about a problem of monumental magnitude. And so I think Dr. Kay, who in the Journal of Neurology 1998 made this comment, I think is spot on, that a passive approach to the diagnosis and treatment of dementia is no longer the standard of care. We're dealing with an epidemic, and it's only going to become more grave as time goes on. But this does provide us opportunities to really fight these diseases head on in an aggressive manner. Okay, now, when you think about neurodegenerative dementias, as Carol alluded to, obviously Alzheimer's disease is recognized as the most common and again is already an epidemic. However, again, the second most common dementia is, guess what? Well, dementia with Lewy bodies. And what's fascinating about this, it's fascinating on many levels, but one aspect that is truly amazing is, dementia with Lewy bodies was not formally recognized until the mid-1990s. I graduated from medical school in 1993. Dementia with Lewy bodies really was not described as an entity at that time. And I was in the midst of my residency when investigators, McKeith and colleagues from Newcastle in England, really, I think, put this disorder on the map, but through some excellent work that they did. So when I was a medical student, I was taught that vascular dementia, so multiple strokes, are the second most common cause of dementia. And that, really this whole concept about dementia with Lewy bodies was unknown, even though obviously it existed, but it was just not recognized. Now, a point that I cannot overemphasize, and I say this to my residents all the time and to families, is, until we make accurate diagnoses, being able to treat diseases effectively is going to be extremely unlikely to occur. We have to identify what we're dealing with and know what's going on before we're going to be able to develop rational treatment approaches and to be able to improve. So this accurate diagnosis is crucial. Now, so some of the hallmarks of DLB, or LBD, I guess you could say, include fluctuating cognition. So patients with dementia with Lewy bodies often will have great variance in their cognitive abilities, so that at some days they're actually doing pretty well. Other days they can seem like that they are near death, where they're completely unresponsive, and it can be a very scary type of roller coaster for patients, families, and healthcare providers who don't understand that this is part of the nature of this illness. Visual hallucinations are extremely common. Parkinsonism obviously is a major feature, and I'll go into that in more detail in a moment. Obviously, exquisite sensitivity to neuroleptics. So patients with DLB who receive medicines that block the neurotransmitter dopamine, we call neuroleptics, medicines like Haldol, these will produce very serious side effects, and so that's a hallmark of DLB. Now, I think something that's a bit controversial, but perhaps less so now, is whether or not dementia with Lewy bodies, or DLB, and Parkinson's disease essentially are the same underlying disease. And I'd be interested what Dr. Stewart's take on that is. I have to say that my belief is that essentially these disorders are the same, and that they're on a spectrum, so that the underlying disease process is the same, but what really influences how the disease progresses and how the patient's affected is where the disease begins. And in a moment, I'll go over some basic neuroanatomy, brain anatomy, and explain what I'm talking about. But it's a bit controversial, but I basically think these disorders are on a spectrum. Okay. As Carol alluded to, Dr. Lewy, in 1912, working in Vienna, a neuropathologist first described the Lewy body. Again, it's been known for decades that this is a pathological hallmark of Parkinson's disease.